going pretty fast. Don't know why, because you have no questions. We're just moving along. Nothing like wasting time, right? Good? Everybody's kosher? Okay, good. All right, so moving into the multi-casualties. So every facility has an emergency operation plan. They call it something different. Every facility, whether it's acute, long-term, care, skilled units, subacutes, they all have an emergency operation plan. Like I said, they might just call it something else. So the components of the plan are listed here. With that said, there's always a plan for what could happen next. The strategies. The biggest thing when it comes to multi-patients or mass casualties is how we triage them, okay? Triaging is important of where we're gonna send this mass amount of people and where are they gonna go in the facility or surrounding areas. And so with the triage categories, black is either expired or close to it. They have a special area. Then we move to the most critical are usually red. And the red means that they have big things that they need. They're in huge respiratory distress. They have huge trauma. They need the main ER because we need all that equipment to take care of them. Then the emergent is your yellow. And those are patients that need a little bit of something, not as bad as the red, but not as less as the green, okay? So they might need IV fluid or that kind of stuff. So we can actually put them in somewhat of a fast track area. So the smaller parts are less equipment-ish, but they still need something done. Where the walking wounded is really the green. They have a sprained ankle, small laceration, they can go to anywhere. Been known to put them in labs or x-rays, well, aside from the x-ray rating area, in the lobby, somewhere they're still getting some kind of treatment, but it's not urgent at all. It's just they need to be seen because they have something going on. So it just depends on what that EOP says for that facility. But again, it's all based on those triage categories for sure. So in the disaster, there's always practice for mass disaster drills. There's a central commander, for lack of a better word, who runs the show. Depending on how that patient is, or not patient, depending on how that personnel is, it could be a manager, the house supervisor, it could be the manager in ER. It just depends what that facility is and who has been appointed that commander who runs the show. The most important thing about these disasters, and the bioterrorism could also play a role with this too, is PPE. We've known with the mask world we lived in and the gloving and all of that kind of stuff that we have to protect ourselves because you just never know what's going to come from these mass disasters. You know, bridges falling has caused airplane crashes, things like that. And so when we talk about PPE, we're talking about levels A through D. So level D is your typical work uniform with scrubs. So Dee Dee likes to wear scrubs, right? And then it goes all up to A. A, we used to say it was like ET, right? Where they had the tunnels, the big scuba suits, scuba without the U, head to toe cover. Well, we've seen a lot of this, right? As we've moved down with our pandemic we've just gone through. So when we look at the biological terrorism agents, those have a different type of category as well. If it is a biological terrorism that's happening with isolation precautions, they have categories as well. So category C, we're going to start at the bottom. C talks about no threat, but it can come later. So something happened, but it's not a big threat, but it can come later. B is some protection is needed. A low rate in death and illness comes from a category B. Category A is the highest priority, potentially high mass casualties, and it takes priority. One thing that happens with bioterrorism is chemical weapons that are used. And so the idea is to get it away, not exposed to skin, inhaling, eyes, all of that stuff. Especially with nerve agents. Every ER has a biohazard shower, okay? One thing is they have to get a copious amount of soap and water or saline for at least 20 minutes is the goal. The biggest thing that we cannot do once we open their pores is blot it or rub it in. We want to blot, not rub off. We don't want to wipe it. We don't want to rub it in. Their pores are open. We want to spray the poop out of them, get them clean and free, and then blot to dry, but not wipe or rub. Because their pores are open and we don't want to rub it in. Okay? So that's how they get exposed to it. Keeping in mind, supportive agents may be needed, the treatment, it's all listed there for you guys already. So, just wanted to point out the most important. So decontam, shower, biohazard, the bio shower. Again, every place and facility and people call it a little bit different stuff, but it's all the same thing as a whole. Questions about any of that?